Not everyone will develop a wound like this from the bite of a tsetse fly, but some people do. You can see it can get quite big with all the inflammation going on. Yeah, usually we won't sample these for the parasite. By the time the person comes in with other symptoms, parasites are gone from the skin. The nice thing is this heals without a scar. When we start to talk about leishmania, you can get these big lesions like this, but they do leave a very nasty scar. So the first stage, the signs and symptoms of fever, and the trypanosomes are in the blood and the cerebral spinal fluid. You get that lymphadenopathy that you can see in the neck. See how big this lymph node is? We call this winter bottom sign. And you can actually pierce this with a needle and get some lymph fluid out of it and look for the parasites in there. Anemia is another sign of trypanosomiasis. This is important because I'm sure Dr. Gosnell will ask you on the exam. You get a very high IgM concentration in the blood. And this is due to a polyclonal B cell activation. The antibodies have very low antiparasitic titers, but you have a lot of IgM in the serum. And you are going to develop anti-variable surface glycoprotein IgG. So as I mentioned before, it's all this inflammatory response that breaks down the blood-brain barrier that allows the trypanosomes to get into the cerebral spinal fluid, because this is the end stage of the disease and much harder to treat than the blood stage. And so we talked about the timing before. But it's basically the inflammatory response that the body is reacting to the parasite. In stage 2, we get the marked changes in the personality, the lethargy, the disruption of the sleep cycle. And eventually the patient will lapse into a coma and die. So this is a man that is in the late stages of trypanosomiasis. This particular man was acting erratically, and so the villagers actually tied him to this tree so that he wouldn't hurt himself or others, and then they called the ambulance. Diagnosis is based on finding the trypanosomes in the blood. We do this with thick and thin blood smears and a Giemsa stain. You want to see the blue cytoplasm and kind of the red purplish nucleus. Has a very small kinetoplast, and again, this is important when we talk about when we compare it with American trypanosomes. And if it's stained right, you can see the undulating membrane. So these are, and they're very rapid movers. So if you were to look at just fresh blood, you could see these moving. And you could sample the lymph node as I showed you in the picture before. Once it gets into the second stage, then the parasites might be hard to find in the blood, and you're going to need to get cerebral spinal fluid. So this is done in the field. You know, here they put the needle into the spine to get the cerebral spinal fluid, which is dripping into this in this tube here. This wouldn't be tolerated in the US, but apparently it's common in Africa. So these are non-specific lab findings. So these in and of themselves wouldn't be diagnostic for African trypanosomiasis. You still have to find the trypanosomes. But anemia and low platelet counts, as I said, the high serum IgM. Increased erythrocyte sedimentation rate. This is a non-specific indicator of inflammation. And as we talked about, you get a lot of inflammation with African trypanosomes. So this right here might be a normal erythrocytic sedimentation, and this one would be a very rapid one. So this one here would be an increase in the sedimentation rate a lot faster, and this one and this one. You can also see Mott cells on the blood smear, and Mott cells are those B cells that are producing so much IgM that they have vacuoles in their cytoplasm full of IgM before it's released. And the increased sedimentation rate is due to rouleau formation. We talked about this with Entamoeba histolytica, but again, the red cells stack on each other because of inflammatory products being that bind non-specifically to the red blood cells, causing the red blood cells to have different charges so they stick together just by electrical forces. So let's compare the two. West African is Gambiense, East African is Rhodesiense. They have different vectors, Glossina papillus for West African, Glossina morsitans for East African. The primary reservoir for West African is humans, where in East Africa it's wild animals and some domesticated animals. The human illness is chronic, long-term, and CNS involvement takes a long time, where in East African, you have a very acute infection that moves along quickly, and within 6 months, the parasites are in your central nervous system. The lymphadenopathy, the Winterbottom sign, is very prominent in the West African, but can be absent or minimal in East African. The number of triple mastigotes in the blood is low for West African, but very high for East African. Diagnosis, finding triple mastigotes in the blood, the lymph fluid, and the CSF if it's in the later stages. In East African, it's either you're going to find it in the blood or the CSF. And the epidemiology is rural populations who use stream as a water source, where in East African it's primarily tourists, possibly game wardens that come in contact with the tsetse fly. Drug treatment is a little bit different, and so we'll talk about the drug treatment. So we talked about Sermon being developed in 1916, and it's used for stage 1 of both West and East African trypanosomiasis. So this actually kills the triple mastigotes in the blood, but it doesn't cross the blood-brain barrier, so it doesn't work once the parasite gets over into the cerebrospinal fluid. It's quite toxic to the kidneys and possibly the skin, so patient needs to be monitored while they're on this. Now, eflornithine is quite interesting drug. It was developed in the 1990s as a cancer drug, and it inhibits, what enzyme, where are we over here? I'm blanking on it, sorry. Well, ornithine decarboxylase, I'm not sure where it is over here, but it inhibits ornithine decarboxylase that the parasite needs to produce DNA. And eflornithine binds quite irreversibly to the parasite ornithine decarboxylase and not so much to the human form of it. And it's less toxic than the other drugs that we'll talk about. Now, eflornithine actually inhibits hair growth, and so you might look at some of your cosmetics because it might contain eflornithine. It just inhibits hair growth, and is included in some cosmetics in developed countries, and they use the profits then to donate the drug to African countries. Melosoprol is an arsenic drug, It's used to treat the late stages of East African trypanosomiasis. So it's an arsenic drug, so there's a fine balance between treating the parasite or killing the parasite and killing the patient. This patient here is showing signs of arsenic poisoning with the discoloration of his skin over here. and giving milsaprol, you're going to have a case fatality rate of somewhere around 5% just by giving the drug. And some resistance to this drug has shown up in some countries. So if you ever watch House, in one of the episodes of House, they use milsaprol, and they couldn't use some types of rubber tubing because it would actually dissolve in the presence of milsaprol. Now, another drug that's kind of interesting is pentamidine. And pentamidine was, well, first off, you have to give it either IV or IM. And it was used for a period of time as a prophylactic drug for African trypanosomiasis. And so they would go in and they would just inject everyone that they could find with this drug as a prophylactic drug. And in this book, The Origins of AIDS, they proposed that since the syringes and needles were not sterilized between use, that it was this campaign to eradicate West African human trypanosomiasis that allowed the HIV virus to spread very rapidly from person to person, that ended up, eventually expressing itself as AIDS. So it's just one hypothesis. So control is reducing human tsetse fly contact. In West Africa, they're going to use things like traps and insecticide spraying and getting rid of the breeding areas of the tsetse fly. What they found out is the tsetse fly is attracted to dark blues and blacks. So they can impregnate this trap with an insecticide, and then the tsetse flies will land on it and get poisoned. So in West Africa, they want to limit human fly contact. Where in East Africa, where you have very few cases, it's mostly confined to case finding and treatment. So that was the African trypanosomes, and now we'll move over into the American trypanosomes. The parasite is called Trypanosoma cruzi. And the disease is called Chagas disease, named after Carlos Chaga, who first discovered the trypomastogotes in the gut of the reduvid bug, the vector. And he named the parasite Trypanosoma cruzi after his mentor, Oswaldo Cruz. Now, some people believe that Charles Darwin, when traipsing around Latin America on the voyage of the Beagle, actually picked up Chagas disease because of the symptoms that he expressed later in life looked a lot like Chagas disease. So it's limited to Latin America, although we do get some transmission in the southern parts of the United States. But the disease primarily is limited to Latin America. Lots of people live in endemic areas, lots of people infected. And because we have people immigrating from Latin America up into the US, it is a concern to the United States. And because people from Latin America can move all over the world, you can see on this map, the darker the red, the more cases they have, that they can end up, in Europe and in Australia. And so other countries, physicians need to be aware of this in their patients that come from a Latin American country. So Let's start here with the reduvid bug. So the reduvid bug is a common name for this particular kind of bug. It's a lot like a cockroach. It's like the size of a large cockroach. And if you saw a large cockroach heading your way, you'd slap it with your slipper, right? So reduvid bugs have evolved so that they only bite at night. So, and at night you're sleeping, and so you're not going to notice this bug crawling on you. And since your body is mostly covered up, the majority of the time they're going to bite your face. And so they're going to bite. They're going to take a meal, and the parasites then, if they ingest the parasite, will multiply in the gut and be excreted in the feces. And so you're sleeping, and after the bug has left, that bite becomes itchy, and you rub it, and you're going to rub that infected feces either into the wound or into a mucous membrane, most commonly the eye. And that's how the parasite gets into our body. Once it gets into our body, it converts from the trypomastogote to the amastogote. And now it's an obligate intracellular parasite of many different types of cells. If it gets into the, like a macrophage, then it can move around the body and get to other parts of the body. But it also can get into the muscle, pretty much any cell. The trypomastogote can invade and form amastogotes. The amastogotes divide by asexual division. So one trypomastogote goes in, but many come out. And every once in a while, this infected cell will break open, and these amastogotes will convert back to the trypomastogote that gets sucked up by the reduvid bug. Now, when you rub that feces into the eye, especially if you rub it into the eye, you're going to develop sensitivity to it, and your eye's going to swell. And when your eye swells, we call, well, when the eye swells, they call it Romagna sign. Romagna sign is a swelling of the eye. If the bite occurs someplace else and you start to swell, then they call it a chacoma. Chacoma is a swelling due to the bite of the feces being rubbed into the bite. So here's Romagna sign. So this woman was bitten somewhere on the face, and then in her sleep she rubbed the feces into her eye. So in the acute infection, then you're going to get the chacoma, or if it's in the eye, you're going to get the Romagna sign. And then the parasite's going to move into the blood and eventually into other organs. And so some of the manifestations as the parasite's moving around is fever, malaise, enlarged glands like lymph nodes, but you develop a hepatosplenomegaly. So hepato, liver, spleen, so you have an enlarged liver and spleen, which is full of amastogotes. It also moves into the bone marrow as well. And yeah, kind of disrupts your hemopoietic system. At any point in time, you can cure through a combination of cell-mediated and humoral immunity. You can clear the parasite from your blood, but very few people, or from your body, very few people actually do that. And young children, I'm talking about infants, the parasite can actually make it into the cerebrospinal fluid and into the brain and lead to death. But for the older individuals, if you don't clear the infection, you're eventually going to end up with two very prominent pathogenomic conditions. The first one is myocarditis. So amastogotes are multiplying inside the muscle cells of the heart. And your heart the heart muscle becomes very thin. So in this case, this person died because they developed an aneurysm in one of their ventricles. This is the aneurysm here. And so the pathologist took a pen light out of his pocket and he put it in the ventricle, showing you that the light is shining through on how thin the actual wall of this heart actually was. And this is all due to destruction of the heart muscle, which is a combination of an autoimmune response. So you're helping your own heart be destroyed, as well as the parasites dividing and destroying the heart. The other disease that occurs is either called megaesophagus or megacolon, as you see here. The parasites are multiplying in the nerve cells of your GI tract. And eventually, when they destroy enough of those nerve cells, you're not going to get peristalsis. And feces is not going to be able to, food and feces is not going to be able to move through the intestinal tract or the GI tract, and ends up building up into a megacolon. So those are the two main the two main pathologies of Chagas disease: the heart failure and the megacolon. Diagnosis: really want to find the triple mastogotes. It's very difficult to find the amastogotes. Now, it looks a lot like the African trypanosomes, except that the kinetoplast is quite large. So large kinetoplast, you can see it has an undulating membrane here. These are non-dividing. These are only in the blood so that it can be sucked up by the reduvid bug. And eventually it will, if the immune response doesn't kill it, it will invade a cell and form amastogotes. So usually it's a C or an S shape with a large kinetoplast, a nucleus, undulating membrane. Yeah, non-dividing, it invades all kinds of cells. The actual pathology is done by the amastogote, which is, it's 3 to 4 microns, multiplies asexually inside the muscle cell, divides by binary fission, and when this breaks open, forms a triple mastogote. The vector is the reduvid bug. So the major genuses are Trypanosoma, Panstrongylus, and Rhodensis are the, I don't think Dr. Gosnell would require you to know all of these, but you should know Trypanosoma and you should know reduvid bug. And here's the bug starting to feed, and here's the bug at the end of its feeding, of which it's dropped some feces here that could be contaminated if the bug is contaminated. They're obligate blood feeders, and they're also bugs, so that even from the smallest nymph stage all the way up to an adult, they feed on blood and can be infectious, and so they're infectious for life. Diagnosis is finding the triple mastogote in the blood. However, people go into this indeterminate phase where you can't find the triple mastogotes in the blood. Parasitemia is very low. So what are they going to do about that? Well, what they do in Latin America is xenodiagnosis. They put like 5 bugs in this cup, and they tape the cup to your arm. They allow the bugs to feed on your blood. And then after a period of time, 1 month to 2 months, they dissect the bug and they look for the triple mastogotes in the gut. I guess it's cheap way to do it. And here's a bunch of kids lined up. Actually, they got 2 cups, 1 on each arm. And so they got maybe 10 bugs per child looking for the triple mastogotes. Now, diagnosis treatment is not easy. There's 2 basic drugs Difurtamox, which is an oral drug, but you got to give it um, 4 times a day for 3 months, usually given for pediatric kids. But because of this long treatment span, it's not readily accepted by the population. Benzonidazole is used for adults, and it's PO, given twice a day, and you also have to take it for 2 months. So the majority of the control efforts are controlling the reduvid bugs in the home. So this could involve insecticide spraying or insecticide bombs that have to be done on a regular basis to keep the reduvid bugs out of the house. The reduvid bugs will feed on any animal, so they don't have to feed on humans. So, kind of like cockroaches, if you leave food around, they'll enter the house. And many people have pets, dogs, cats, guinea pigs, that the reduvid bug can come in and use as food. So continually controlling the reduvid bugs around the house is the most effective way of preventing the disease. This is a cartoon about sleeping sickness. I don't know, once now that you understand how serious sleeping sickness is, this might not be so funny. So if that's it for today, if you have any questions, you can write it in the comments. Otherwise, I'll see you on Friday, and Dr. Gosnell will be talking about leishmania.